So we're now going to open up for questions. We have a microphone on either end of the room. And if you have questions, we'd like for you to just step up to the microphone and ask those questions. And I don't see anybody over here, over there. John, did you have something? No? Nope, here we go.
Hi, this is a question for Brad. I just wanted a clarification. When you were introducing the human into the de-identification process, it looked like to me there was a sort of peak of systems learning, and then if you added a human, you would increase the de-identification or increase the, is that correct?
I'll give a clarification.
Great.
So basically it was what happens if the human gets to observe all of the residual identifiers. And so
Residual meaning after the machine learned everything.
The machine was already doing its job. And so if you don't apply that hiding strategy, then the human would get to see everything, right? When you do apply the hiding strategy, they get to see a lot less than what they did before. So it was basically you remove 99% of all the stuff you wanted to remove. What happens with that final 1%? That was an analysis of that final 1%.
Yes.
Hi, I also have a question for Brad. So I am not an IT person whatsoever. I'm used to my laptop, and the only thing I know is the little recycle bin at the bottom of my computer of how to get rid of information, but it really doesn't go away. When you're scrubbing data from people and getting rid of that, how is it destroyed? Where does it go?
So we use two different resources, at least in the work that we do. So on one side, you still have all the identified medical record, which is still being used for operational purposes. Then you have the software that is basically doing the scrubbing. And then after the scrubbing's done, you push that to a completely different set of servers. So that stuff that you removed, it's not even on the computer that's housing that data. It was still back on the side that was allowed to see the identified information.
But it goes onto a server, so it's never really going away.
Well, it's no different than if it had still been in the electronic medical record to begin with. So you're right. In fact, you don't want it to go away, because if you did, you would not be able to treat your patients.
Thank you.
Not to be facetious.
And I would just add to that. I mean, it's sort of the HIPAA concept is that the identifiable information stays within the provider, and they can have all of that data, and they can do that de-identification process, and they can keep all the leftover stuff, right? Because that's theirs, and they need it for other purposes. But then when it gets actually moved out of that HIPAA confined sphere, that it's just the de-identified piece without all the leftover stuff, without all the unidentifiers. It then moves out of the covered entity, the HIPAA covered entity, and move to research. So it's the actual recipients of the de-identified data don't need all the other stuff, but the other stuff can stay with the people who could have used it to de-identify in the first place.
Thank you. That's helpful. Thank you.
But full clarification. It's one of the reasons why the person who is doing the de-identification can't then say, I'm working with de-identified data, right? You can't just say, hey, I've got identified information here. I did my own de-identification. Now I'm only working with de-identified data. It doesn't work because you had all the identified information to begin with.
Yes, sir.
Steve Jaffe from UPenn. Thanks for really great talks. My question is also for Brad. So, what happens when you speak last? In describing the Vanderbilt project, it seemed to me, if I understood correctly, you were basically scrubbing dates, and then, right? I mean, those were some of the things that were removed, and then in describing the Santa Fe project, for the most part, dates were left in. And that seemed to me an admission that dates are actually really important for the value of the information. And I'm wondering what the implications are for the value of the Vanderbilt project from the fact that you're removing dates. It'd be hard to tell, for example, when somebody began treatment for their cancer and when they had progression of their disease without dates that were at least reasonably accurate to the...
Yeah. So this is why I wish I had hours upon hours to talk to you. What we did at Vanderbilt was we basically did random offsets for each patient. So we didn't just remove the date. We actually substituted each patient with a random offset date that was within the range of -1 and -365 days. So you still have the ability to bound what's going on. The implication of this is that you can look at what happens to a patient over time, but you can't do an aligned epidemiological study across the entire population like you could do in like the Sanofi data sets. So it depends on what you're using the information for, right? So this is one of, this is why I said I wish I had hours. There was a slide that would have showed up at the very end that said, one of the challenges is that you need case studies. You need to know what the information is going to be used for before you actually disclose it, because you are redacting things and you want to make sure that you keep the data in a useful form. So if what you're going to be doing is an epidemiological study, dates become extremely important. You want to retain that. Geocodes obviously don't become as important at that point. But if you're doing the types of personalized medicine studies that we're doing at Vanderbilt, where it's I want to understand what happened 3 months from the initial start date of a particular pharmaceutical, then doing it on an individual patient basis ends up being more desirable.
And just a very quick follow-up. The random offsets, were they applied to every date in a patient's record? Or,
Yes.
So in other words, each date got its own random offset,
No,
or each patient
got its own random offset.
So within a patient, the
You got it.
intervals were
Yeah,
correct?
sorry for the
Okay.
confusion.
Thanks.
I took the long route.
And I sometimes have clients that just need the intervals, and they want to de-identify, but they're trying to work with the safe harbor and not go the statistician route, which is more involved, but for a smaller covered entity may not make as much sense. And so what they'll do is say, we need the time from the start of therapy to the time of the next course of therapy. And so rather than, those are not dates, they are, time differences. And so it's like, T plus 1, T plus 30. And so they'll look at that. And if you look at the safe harbor, it says you have to remove dates. It doesn't say you have to remove intervals like that in periods of time. So often we use that as a way of working around the safe harbor, basically.
Yes, sir.
Now, Jeff Botkin from the University of Utah. Terrific panel. I have two questions for Brad. First one is a lot of momentum, of course, behind HIPAA and the safe harbor standard, as we've heard, and there's possibility of extending that further. To what extent is that standard evidence-based? Is 18 the right number? Is that based on actual sifting of the data analysis as you've done? Is that the right number? Too high, too small? Second question, I love the concept of adversaries. So it seems to me there's robust literature that you've been a leader in around from informaticists sort of trying to crack the code. To what extent have there been any real adversaries out there? Have there been research databases that have been cracked by folks who indeed have malintent for pursuing these types of data?
Thanks, Jeff. Okay, to come back to the first question, is the 18 correct for safe harbor? Some of that was based on, a lot of that was based on evidence from the 90s. And so, for instance, the Sweeney attack on William Weld, that was almost, if I had to take a guess, that was one of the main drivers behind 5-digit zip codes, exact dates, those types of things. So the policy itself was based on some evidence. There were some arbitrary cutoffs that were made, like geographic regions had to have at least 20,000 people. And that was also based on some evidence from the Census Bureau, but that information was never really made public. But it was known within the federal statistical agencies. Now, there are a couple of other thresholds that are used in the federal statistical agencies. So some use like 100,000. Other ones use like 5,000. It depended on their risk tolerance. Whether or not that 18 was sufficient, to be honest with you, I would argue that it probably was at the time. Whether or not it will be 5 years from now, I don't know. I think one of the challenges is that what I was alluding to with big data is that it's not just that the data is getting bigger. It's that the dimensionality of the data is getting bigger. So that as you add more dimensions, it becomes more identifiable. As you add more people, it actually becomes less identifiable. And so if the rate of the dimensions is growing at a faster pace than the number of people in your studies, you might have a problem. And so we might have to look at what those features are that are now coming into play that are showing out in external resources. That's the real tricky thing, understanding how the information gets linked for committing the attack. Now, that leads into your second question, which is, do we really have instances where the information is being exploited beyond a single computer scientist spending, like, lots and lots of time and graduate students' capability? There are a couple of instances in which it has been shown it is possible. So I think Latanya has actually been showing over the last year how easy it is to identify the Washington State's discharge databases. She's done a case study with at least 40 individuals who have been identified, and she worked with a reporter from, I think in this case it was Bloomberg News, to confirm the identifications. Now, that said, it's not completely clear that that data was actually de-identified according to HIPAA. But so I'm just saying that there are cases that are being put out there. Now, are there people being harmed and bringing about suits? To the best of my knowledge, there are no suits that have been brought about that show that de-identified information is leading to actual re-identifications and exploitation of individuals. Does it mean it doesn't happen? I don't know, because absence of proof is not the same as proof of absence. What I will say is that it's 12 years of evidence now with respect to the safe harbor standard or just the privacy rule and the sharing of de-identified information. I would say we're doing pretty good because you don't, to the best of my knowledge, you don't see any whistleblowing. You don't see any claims that the information is being exploited by information consolidators to do this. That would be my argument.
I would just add that we're also at a time with the Affordable Care Act and health reform, though, where I think people are worried that that's gonna happen more. It's whether it will or not, I think, is the question. But there's now an opportunity with all of the quality initiatives and the incentives in that law to there's a lot of exciting possibilities in terms of the data sets that may be there, the electronic health records and what have you. So I think as that grows, and part of the high-tech statute, the increased HIPAA protections were because there was so much opportunity with the data. So I think Brad is exactly right with respect to where we are today. I don't think there are suits and such, but I do think everybody gets so nervous when we have more data available. And so I think that's part of the rhetoric that you hear around, because there's going to be a lot more out there.
Wendy?
Yeah. Wendy DeMark, Wanafried, UAB. And I have a dilemma here. And as we all know, recruitment for clinical trials tends to be a big problem that we challenge. I won't say problem, it's a challenge. And one of the practices that we always used to do, I'm looking to the panel because you're very sage and you give such great presentations, for a solution to a problem. We always used to send main outcomes results, the paper, to our people that participated in the trial, and that was met with a lot of favor, and really made people very jazzed about participating in a clinical trial and much more likely to participate in the next one that came along, or a relative. And now we can't do it because usually main outcomes articles come out after we've had to scrub the data and that sort of thing. So maybe if any of you have solutions for that, or maybe somebody in the audience would have solutions to that, because I think we need to bring back why people participate in clinical trials, and we're kind of losing some of this with all the fear.
Can you tell us a little more about why you're not able to do it now?
Our IRB will not. There's a certain length of time that they allow us to maintain that identified data, and oftentimes the review article is not published at that time.
There's nothing under the privacy rule that as long as the data is de-identified, it should be in an article. There shouldn't be any identifiers within that article, right? So there's nothing under the privacy rule that would, tell me if you think that would prohibit that. So I think I'm wondering if it's not a change in IRB approach to it, because there's not a change in the rule that has, we can talk to Patricia or whatever, but there's not a change in the rule that that would lead to that change in outcome. So they may have some concerns as to, and that's causing them to view it differently, but.
And totally, legal aside, and I agree with Melissa, that's one thing that you are sending out as a possible recruitment tool, but it doesn't mean that there aren't other things that you can send out as sort of an engagement tool that aren't the main outcomes. There are websites, there are forums, there is a desperate need, an unmet need in a lot of patient communities to get connected with clinical trial opportunities and research opportunities. And so one of the ways to increase that is just creative, think outside the box solutions, websites like Patients Like Me, where you can plug into vast patient networks of people who are eager to connect with each other and with possible solutions. I just mean, don't be discouraged because for whatever reason, one avenue has been shut down to you. There are lots of other ways to recruit patients because the need and the enthusiasm level and the sort of, in some cases, desperation is vast.
Yeah, it's just, it's something that you want to give back to patients that have participated a couple of years on your study, and we've been faced with the fact that we have to scrub everything, so we can't go back.
I just wonder if maybe there are shorter versions that they would allow out, or something more modest that would meet the patient. Wow, I really made a difference here in participating, meet that need without being, while meeting the IRB's concerns, and just something, I don't know, more summary or something. But I don't think there's a law change that's causing that.
Thank you.
Yeah, I would say, Wendy, thanks for bringing this up because I think there's two issues here. One is your idea, which I think is important, of reporting back a responsibility to people who actually give of themselves to participate in our trials. But the other one is this entire issue of consistency of application. I mean, we have these rules, but you have different places decide on different things and set different parameters. And we've never been able to tackle that. We all know it's there. But I appreciate your bringing it up. Yes, ma'am.
Susan Ellenberg, University of Pennsylvania. This is a question for Alice. I have very little expertise about HIPAA, but I'm just curious with regard to this issue of healthcare operations. The implication of what you were saying seemed to me that if there were an institution that wanted to do a study like the support study in their own institution, where they had, clinicians who used different percentages across, and they decided to do a randomized study of 85% versus 95%, however the support study did, to decide whether there should be a standard within their own hospital. Are you saying that could have been done, that could be done or could have been done under the HIPAA regulations without any consent at all?
Yes.
Rich?
Rich Shilsky from ASCO. So a question also for Alice. So getting back to this issue about generalizable knowledge and, where you cross over from, collecting data for healthcare operations and then making observations and making that information widely known. It seems to me that part of the definition of research that sometimes gets overlooked here is the first part of the definition, which is a systematic investigation that results in generalizable knowledge. And one could argue that, if you're collecting data for healthcare operations and have no pre-specified hypotheses and no organized research plan, and you just observe trends in a data set that you've collected for another purpose, that most people would not consider that to be a systematic investigation. I'm just curious as to get your thoughts on that, because obviously the conundrum that you posed is very important to learning healthcare systems. You can't do much learning if you can't actually disseminate anything about what you observe.
Yes, I agree with you, and I think it speaks to the sort of larger issue, which is that these definitions are imprecise and largely overlapping. And just the way you could say that something is litigate that something is designed to contribute to generalizable or not, you could take the first part of that definition and say it wasn't systematic or not. So I don't disagree with you, I think, but what you're saying is directly to the point of who are we and how comfortable are you with saying, no, I'm 100% sure that this was not a systematic investigation, and therefore I'm not going to go through the research protocol, I'm not going to do consent, I'm not going to do IRB, and run the risk that you're wrong. And I just think there's now a fear climate that you're going to be wrong. And given that it's so easy to make the argument on the other side, and maybe not perfectly, but enough, the argument is strong enough that there just tends to be a general, let's just kick it into the research category to be safe. And that's exactly what we want to get away from, because you're exactly right.
Any other questions? So I have one I want to just pose really quickly. Brad, you, or two actually. Brad, you mentioned you did focus groups and some community engagement work as a prelude to some of the work that you were developing in your own tool. Was any of that work spend any time discussing what patients viewed as risk, real risk?
It's a good question.
Yeah.
I don't think that I'm the one most qualified to answer that one because I didn't run the focus groups.
Okay.
I think, so I'm looking through people at Ellen Clayton, if you can see it, because she was involved in that, and I think she's going to be talking a little later in the session. So I'll defer to her if she wants to talk about that.
Are you going to cover that later?
I certainly can.
Okay. I think it's a central issue here because what I'm hearing is we have risk issues. We have a fearful environment, which makes us very conservative. And at this point, we don't have any real identifiable situation in which somebody's actually been harmed. We have potential scenarios and people have explored possibilities. It just strikes me as a strange environment to be in, but I don't think it's atypical. The last question I just wanted to throw out to the panel is the whole concept of privacy general is an evolving thing. I mean, we have a young generation that's not really overly concerned about that. I was in a meeting a couple of years ago where everybody was freaking out about privacy and all of that, and somebody pointed out that everybody in the room was of an age, and the other people outside the room were not of that age. And God knows what my phone and Angry Birds have been telling the world, what I've been doing in the last few minutes. But I'd just like to understand what you think in this current climate, understanding that the people who are making policy at the federal level are of an age. But do you see this changing based on what's happening in our world in terms of the availability and the willingness of people to share?
So I can jump in on that early?
Yeah, you please.
Two things. There's been a lot of interesting behavioral economics research done over the last 10 years looking at how people make decisions about privacy. A lot of that work has been done by Alessandro Acquisti up at Carnegie Mellon. And one of the things that they've seen is that people, when they get a service in front of them or they get a new technology in front of them, they're really happy to put things out at that time. And then at a later point in time, there's a lot of remorse that kicks in, and that they want to take that information offline. And so in the EU, for instance, they're starting to define this as the ability or the right to delete information. And so just because people right now may feel comfortable putting information up, when they go to get a job, and once they're graduating college 5 years later and there's pictures of them doing all sorts of crazy things, they may not feel as comfortable with that. Now that said, the second issue is that you're starting to see a movement towards people, some of the younger generation, that are no longer using some of these openly available resources because of the fact that they feel as though it's too open. You're starting to see a lot of people move away from Facebook just because they find that, their parents are on Facebook and they don't want to be in the same environment as their parents. So I think I don't think that it's actually a generation that fails to care about privacy. I think it's just a changing definition of it, and that you're always going to see people who have an opportunity or an interest in either having secrecy or things that they want to hold back. And it's going to be an option, right? And, it's not about always, finding a model for protecting everybody's identity all the time. There's going to be plenty of people who want to openly disclose, and they should have the ability to do that.
Right.
In the healthcare context, one of the other big issues that we find right now with the legal environment is that so much of the data that is out there on the internet, so much of big health data isn't protected at all. HIPAA does not apply to data, it applies to entities and the data holders. And so you're absolutely right that the willingness to share is increasing and with the young whippersnappers these days. But there's also a fundamental lack of knowledge as to just how unprotected that data is. And so we do a lot of work in trying to think about what is a baseline comprehensive privacy law or regulatory framework. What does it look like? Because health data that's uploaded onto the vast majority of social networking sites or even internet sites in general has absolutely no legal protections. And it's our understanding that even though children or young adults might not think that they care, they do think that there's some protection for their own data because they think that, they don't know what HIPAA is, but they will think that there's some legal protection for data that's out there if it's of a personal, sensitive healthcare nature, and that's just not true. So part of this discussion is with the evolving tolerance for sharing, there needs to be an understanding or sort of something formulated to meet that so that the risk is not so that the privacy of the data is not as exposed as it is right now, even as people are more willing to share it.
And I completely agree with that. And I guess I think that there's a lot of discussion outside of the healthcare context about fixing the problem that Alice just described. And should we have a national privacy framework? And that right to be forgotten in the EU, I mean, shouldn't we have a right to be forgotten also? And I think we get criticized in this country as not having an adequate framework. That sometimes makes it, whether you agree with that or not, it sometimes makes entities in the EU and other countries less willing to share data this way. And to the extent that affects healthcare research, I would think that would be a significant concern. So HIPAA is one little piece, but we're lacking any protections for anything that that's outside of HIPAA. And there's the Federal Trade Commission. There are some sort of standards out there, but this is what the ANPRM that Holly was talking about was really getting at. Okay, researchers, there aren't really rules once they get it. And I deal all the time with academic medical centers who had a researcher who left the laptop totally unencrypted in the car, and it was stolen, and that's not protected. But it was data that patients consented would be used for research, and now it's sitting there. So I think people are going to really continue to struggle in the research context and the healthcare outside of HIPAA context, and in the much broader social media, all of the data, all the online data context. And I think there's just a lot of conversations happening not very far from here on the Hill about those privacy frameworks. I think it'll be a long time before something comes to pass, but I don't think the conversation's moving towards less privacy.
One last question? Go ahead.
Deborah Collier, Patient Advocates in Research. What has struck me about the conversation, and there have been a lot of really good points about it, is that we started with the framework of what the rules are, and there seems to be an absence of what real life happens when patients actually get diagnosed. And so in bringing that through, Alice, you brought up that there was a difference between research and healthcare operations, and yet in every doctor's office that you go to, no matter what you have, you're signing a HIPAA authorization. So from a patient standpoint, again, we don't have a separation of research versus healthcare. From a patient standpoint, you're signing HIPAA for anything you want to have done in the system before you even see a doctor. You're signing consents to get medical treatments. So the word consent and informed consent in research really has no connotation from what we're talking about. And yet rules and decisions are being made, it seems like in the absence a lot of what actual thought processes go through when you are a patient and have to go through the system. So I guess that was one of my questions is how does the implementation of HIPAA and some of the other protections that we have within research actually work for patients when they're faced with some type of medical condition that unfortunately a lot of times can turn into cancer?
I don't know. You're absolutely right, and it's why the consent discussion is so complicated and in many cases so contentious. And the notion of informed consent as a concept versus a HIPAA-defined authorization as a form, because as you say, you're absolutely right. You're signing something when you go into a doctor's office and you don't really know if that's for treatment or blood drawing or future research. So the patient community is an integral, and if not the most important part of so many of these how to implement consent and how to implement these changes that we're all talking about in a perfect world from a legal or a regulatory standpoint. So often the roadblock that a policy person runs into is a patient who says that wouldn't work for me, what you're deciding, what you're talking about. And to be fair, often for providers as well, we say it really should look like this, and this is where the consent should occur at the point of this point of care, and the doctor says, that's not going to work for me. So there's the policy discussion and the what should it look like legally, and then there's the how does it actually work when you are faced with a particular diagnosis. And there's no exact right answer, and very often it's going to be different in whether it's a small doctor's office or a large hospital system or where you are in your patient process. But I'm encouraged to see that over the last 5, however many years, the patient advocacy community and the patient engagement movement has become much more of a focus of all of these discussions.
Last question.
And I think there's one over there
Sorry.
as well.
Next to the last.
Next to the last. Angela Bradbury from the University of Pennsylvania. Thank you. This discussion has been very helpful. I have a question that comes back to earlier comments about how we engage with patients and how local IRBs interpret HIPAA and other regulations. While a lot of times in oncology we recruit patients at the time of diagnosis when they're signing up for treatment trials, perhaps, there are also a lot of studies, population-based studies, behavioral studies, where we might want to recruit out of a healthcare system. And some IRBs will permit searching through EMR for patients who are candidates for a particular study, sending out a letter introducing a study as a way of recruitment. Whereas others really have restricted it to only when the patient is sitting in front of you. And this holds also for recruiting family members. So for some, they will permit you to contact a patient, and the patient can give you information on the family member, and the team can then directly contact family members. And others, the family member has to call back in. And so when we think about barriers to research, this is one that I've seen, and as we do these studies across multiple sites, at some sites we might be permitted to use one recruitment strategy, whereas at another site we're not, and it's raised some conflicts and questions about the interpretation. So I'd appreciate any guidance you have there.
I don't know if it's guidance. I would just say that you're not alone, and that's something that we wrote a paper last year on this issue of multi-site research initiative challenges, and variances in local IRB policies was one of the things that came up first and most often. The problem with having scientists, clinicians, providers kick all of their studies into the research categories is that it puts a huge amount of responsibility on the IRBs to govern how things shake out. The IRBs become really the be-all and end-all determinants of how things are going to proceed. And there are variances in risk tolerances. There are variances in institutional policies. And if you have 3 different sites and one IRB is very conservative and one IRB is less conservative but has this other restriction because it's a matter of internal policy, it can grind things very quickly to a halt. So we want to decrease reliance on IRBs to set research policy parameters, and at the same time rethink what makes sense from an IRB perspective so that it's slightly more consistent. On the other hand, the institutions feel very strongly that their IRBs are a representation of their values, of their patient values, and so it's hard to say that any one of them is wrong. I understand what you're saying, and there are strategies, as you well know, that people use with designating an IRB of record or taking one IRB and just deciding to agree with that. But it's not to say that doesn't cause a great deal of conflict in these what we want to see more of is multi-site cross institution studies. So I'm sorry.
And I would just say that you absolutely can. There's an actual exception in the rule that allows you to do reviews preparatory to research, as you know, and to do exactly what you're saying and to reach out to patients. So that could not be more clear. It's not a question. But that said, you're hearing a lot of variability in IRBs as to whether they read the rule that way. But that, to me, is just one of the classic examples. Like the rules specifically gave you permission to do that kind of research.
So it's an interpretation or it's a tolerance of the local IRB? That's permitting restrictions in that, if the rule would permit
that type of recruitment?
I mean, the rule, I think the rule is very clearly designed and in fact says that you can do reviews preparatory to research and that a covered entity, a hospital, can reach out to its own patients. Now, the researcher can't because they can't have that contact with the patients yet, but that the covered entity absolutely can reach out to the patients. And it was designed, it was put in there, I think, to facilitate recruitment. So that, I think, is, and I'm sure I would even say interpretation. I don't think it's in the range of what the interpretation to the rule would lead you to, but that doesn't help you if that's where the IRB has decided to be.
Thank you.
Now the last question, truly the last question.
So this is just a comment to throw out to you for your comment back. You know, ultimately, I think those of us who treat patients and also do research have as our absolute primary goal to serve the needs of our patients and also the wishes, the desires of our patients to a very, very great degree. And that takes precedence over everything, you know. And we see, those of us who treat patients, day after day in the clinic, we will have a patient with a diagnosis with cancer who says, I want you to use anything about my life to cure this disease, please. This is a mandate we hear from our patients. And I just think these conversations, as important as they all are just so paternalistic. If you can view them that way, if you listen to these patients standing out, yes, I know we need to do much of this stuff, but sometimes I think that voice gets lost in all of this about how we have rules because, God forbid, something that is relatively unlikely might happen. So what should I be saying to these patients? Because I have to say, I'm sorry, we'll do the best we can, but, basically there's very limited things we can do with all of these data and your life that you're giving us. Comments?
Okay. Do you want me to go out on a limb?
Well, any of you, this is what we're all struggling with here. How do we do the very, very best we can? And is this environment the very, very best we can? I think it's not at all, because we have to be willing to be brave and maybe take some flack for having some mistakes happen and with the goodwill of trying to do the best we can for the patient.
And I think we've got about 1 minute for each of you, okay? And I just want to say, though, I think part of Steve's challenge to us earlier today was, out of this whole workshop, we should be asking that very question. Is this the best we can do? Okay, 1 minute each.
I'm going to paraphrase a friend of mine who said, what's the worst that happens? We lose an entire generation, right, in terms of their protections. But if you look at this on a bigger scale, I think that there's more than what everybody's doing here, what we've just been talking about. There are places that are allowing patients to get involved in research, right? I think PCORI is a step in the right direction. I don't think that it absolutely precludes the inclusion of their data from research. There are plenty of studies that are being done on fully identified medical records. It's done usually under a waiver of consent, but that's a different story. But the biggest challenge that you run into is that for every case, for every individual who has the disease who wants to participate, you now have to find the controls, right? And so there's a lot of people who, if you're doing it on large scale populations, and so you do have to have this ability of how do you get everybody involved while mitigating bias? And that's a tricky thing.
No, I understand the scientific, research design. That's not the issue I'm trying to get to. But, the issues of research design are very important, obviously. But what I was speaking to is something a little bit different. You can have a patient in a very clear research design, but the ability to do everything you can with their permission is inhibited by many of these rules.
Well, and I completely agree, and I think, we hear that all the time from patient groups, that we want to do this, and we want the next group of people not to have this disease or for it to be cured, so do something. And I think HIPAA has been a challenge for research. I think this new rule is a step in the right direction, but I don't think it clears the roadblocks that you're talking about. I think some of what Alice talked about may in fact be a better structure, because consent is one piece of the game, but we also actually commit to protecting the data and do other things around it. There's a whole bunch of steps that go around it that might make consent less important, because it's also so poorly understood that is it really even the right tool to be hanging so much on. So I think a lot of the solutions that Alice talked about actually would move us to a better framework that's, that might clear the way for what you're talking about.
Thank you so much for your comment. And Melissa's right that we hear this all the time, and I appreciate you bringing it up now, and I really understand what you're saying. This is not to be contrarian at all, but part of the conversation in this is that the sickest people also tend to be the most vulnerable. They value privacy low because, as you say, they're like, take everything, do anything with it, just for the love of God, help me. But that's not to say that therefore we should have no protections, because then they expose themselves, and it's not always that we want to think that all doctors and clinicians or researchers have perfectly pure intentions, but it's not always the case. So there does need to be something in place to protect people when they're at their most vulnerable. And so the challenge is to put protections in place that are not paternalistic, that are designed with patients' actual engagement and the patients in mind, and that there's a spectrum, and so that data becomes more available as people need it to be more available. But then on the flip side, there's also stronger protections in place for the most vulnerable populations, and that's why there's everything is a spectrum, everything is a balancing test, but it's certainly part of the conversation.
So if you would, join me in thanking our panel for a good start today. Thank you guys very much. And with that, I believe we have a 15-minute break. So if you'll reconvene by 10:30 and we'll start the next panel. Thank you all.